Welcome to another session of Pulp Nonfiction. Today I have with me the esteemed Dr. Pommy Hallen.
Esteemed, wow.
Esteemed, of course, the best. I've been warming up for this interview for a while.
Yeah,
Save the best to the end. So I first bumped into Pommy in San Diego when you were, I think, finishing off your residency, and through the, network, she'd had some of my old notes for the exam, which I got from Mike Matwichuk. And then from there, you worked as a general dentist for a number of years in the Valley in Surrey, saw the light, went into endo, and then you are working in Surrey for 12, 13 years now?
No, just about, we're coming up on 11 years now.
11 years. 11 years. And then we work together in Langley at Township Endo, and we also do a hands-on endo course, BC Endo Solutions, which we might parlay into an online thing in the future. We're kind of kicking that around a little bit. But today, we're going to be chatting about pain medications and teledentistry in this time of the COVID pandemic. So, Pommy, if you could just maybe give us a little bit more of a background about yourself, and then, get rolling with the pain medications.
Sure, yeah, no problem. So thanks a lot, first of all, Joel, for allowing me to do this with you. It's pretty exciting. It's my first time doing this. So with this podcast or a video conference type of interview, so that's kind of cool. I worked for about 8 to 9 years at as a general dentist. So I know what all general dentists are going through. Patients are calling you right now and they're complaining, and you feel bad that one of your family members is in pain. Mm-hmm. But right now, during COVID-19, it may be safer for people to stay at home. Mm-hmm. After the general dentistry, I went to the University of Southern California, and I did my specialty degree certificate in endodontics at USC. So go Trojans, fight on. And then I came back and I bumped into Joel through the years at different conferences, AE and whatnot, and we practiced together, and privileged to work with Joel as well. So it's a great opportunity. We have a great gang of people with us. What we've been learning about COVID-19 is that sometimes, it reacts to people very differently. You could be totally healthy and have no symptoms. In a matter of days, you're in the ICU, intubated, and you're critical. And it seems to fill up your lungs with this mucus, thick secretions. And there's been some chat about how NSAIDs could make this worse. So the main weapon that we've had in endodontics or in dental pain is using a non-steroidal anti-inflammatory drug. And the way this works is that it actually helps to decrease the inflammatory receptors on C fibers, A delta fibers, so that there's less discomfort inside the pulp. If we can't use an anti-inflammatory, this neurogenic inflammation that you have in the nerve causes quite a bit of pain. So we're trying to figure out, how do we deal with these people in teledentistry? And so a lot of protocols have been done up. One of the ones that we're using out here in beautiful Vancouver is with the AE. Dr. Hargraves came up with a protocol and a few questions that you should always ask. So my steps that I take so far with teledentistry is mainly the phone. We haven't used any apps in our offices at this point where we can do video conferencing, but I think in dentistry that's going to change now. In medicine, for remote locations, they already have teledentistry. Babylon Health, which is a big initiative by TELUS, which is a huge wireless carrier in Canada. And medical doctors can talk to their patients over the phone, diagnose tests, and prescribe tests, and then go over the readings with it. I think that may happen in dentistry now due to this pandemic. What I've been doing is really using these forms that Dr. Hargraves has come out with to find out, how critical is the issue? If the patient can stay at home and is healthy and has no issues, versus having the risk of coming in and catching COVID-19 or being even outside and spreading to other people, what's the cost and benefit? So we have to kind of weigh that as we're going through this telephone interview with the patient. And some of the things we have to ask them is, what is their level of pain? And there's a screening tool for the level of pain. You tell people, on a scale of 1 to 10, if 10 is the worst pain that you ever had in your life, 0 is no pain, how would you rate this pain? And the patient's going to tell you, oh man, it's 11, it's 11, it's a 12, right? They always tell you that. We all know that tooth pain is really, really bad. And that's why we stay and work, right? So that's why we have a job, endodontist. So we like tooth pain. But do we really want our patients to catch COVID from us, or do we want to catch it from them? Not really, right? We're trying to flatten that curve that everyone's talking about. So you want to kind of trip them up with a little bit of a secondary question. You want to ask them, hey, how many nights have you not slept at nighttime? And if they say, oh, no, I have no trouble sleeping, well, then you kind of know right away, this really isn't a true emergency. Another great question is, you know, when you are chewing on this tooth, they've told you it's the upper right or the upper left or wherever it may be. Are you able to chew on both sides of your mouth? When you have food in your mouth, are you chewing on both sides? So give them an open-ended question. And they say, oh, no, yeah, I'm chewing on both sides. Everything is great. It's only when I have hard things. Then again, you know, is it really a 10 out of 10 or 11 or 12 out of 10? If they say that they haven't been asleep for 3 days, that it's throbbing and aching and radiating, they can't chew on that tooth, they're on a liquid diet, and they say they're 11 or 12 out of 10, then I would agree. They're 11 or 10 out of 10. They are 11 or 12 or 13 out of 10. So now we have to treat these people. And we'll talk a little bit about that, how we can do that without using NSAIDs or without using hand pieces in the office or generating aerosols. Then the next thing that you want to do on your screening conversation is ask about swellings. You have to rule out, is this a irreversible pulpitis, a reversible pulpitis, or is it a swelling? And I just missed one thing. There's one other thing that you could ask is, you can ask about the quality or characteristics of the pain. When a patient has hot or cold, there's another question to kind of trip people up on. So sorry, when they have cold, is it a sharp stabbing pain that just occurs in a few seconds? Or is it a pain that kind of works its way up and lingers and throbs and just radiates and it stays with them for greater than 5 to 10 seconds? Obviously, the money answer is the second answer. Hey, it comes on in a few seconds, it really hits deep down and it radiates to my cheek, up into my eye, down into my neck, then we know it definitely is a true emergency. It's not something that the patient is lying about.
Yeah, and also they tend to be less inclined to negotiate when they're in pain. They're like, yeah, whatever, man. I got to see this. I'll see you today. If they start broadcasting or predicting problems like, well, I don't know how I'm going to feel next week, and it's not an emergency today.
Exactly. Yeah, people are in pain. They want to be in yesterday.
Yeah, and they'll accept anything. I'll come in at 10 tonight. I don't care, man. Do what you got to do.
Yeah, exactly. That's a really good, that's another great indicator. So, you know, with the medication that we use, we need to figure out, you know, can I treat this patient over the phone? Is there something else that I have to refer this patient to a medical, is it a medical hospital emergency? We don't want people to be going to the hospital, but you're going to ask questions like, are you having any trouble swelling? Is it are you having any trouble swallowing? Is it a bilateral swelling? Are you swollen on both sides? If they're having trouble swallowing, breathing, and they have swelling on both sides of their lower jaw, then you know that could be a Ludwig's angina situation here. Mm-hmm. Then you have to send them to the hospital. Before you send them to the hospital, I'd probably reach out to your local oral surgeon that may have some rights at the hospital, and also warn the emergency department that this person's going to be coming in. They're swollen, and you're not sure if they could have COVID or not. Okay? So we have to differentiate between just the irreversible pulpitis that we can easily treat over the phone and by prescribing medications versus a swelling, an abscess, an extraoral or intraoral swelling, or a facial space infection. So you have to figure those out, and there's other questions like I just discussed with you that we can talk about. Of course, if there's trauma, I've had a few calls of patients and their little kids have fallen. Everyone's at home, spring break, they've fallen off their bike, broken their teeth. Of course, you're going to talk about that. You're going to talk about it over teledentistry. Is there a blush of the pulp? Can you see the pulp? And you know, these patients, we probably really do want to treat. And so you want to set up a way to help this poor 9 or 10-year-old if they've subluxed their teeth or they've chipped their teeth and close to the pulp, and how we're going to fix them. So telephone dentistry versus actually seeing these, you know, young patients that just had trauma that you need to fix up versus sending them to the hospital. So I guess the question we started was now medication. So that's a little bit about teledentistry. I guess we can go back and talk a little bit about medications. And I think I want to start with what the gold standard has been before COVID-19. So the gold standard, again, in dentistry or in endodontics for dental pain has been an NSAID. And you can pick your favorite NSAID. And most dentists' favorite NSAID is ibuprofen or Advil. 400 to 600 milligrams has been amazing to help people with dental pain. Again, today in COVID-19, that may not be something that's recommended. If it wasn't in the era of this pandemic, another great little trick is to add 500 to 1,000 milligrams of acetaminophen at the same time with anywhere from 400 to 800 milligrams of Advil. And it's like when you're, one of my mentors, he always told me, it's like when you're piloting a plane. You take off and you land. That's an important aspect. But when you're in the air, you're on autopilot. But there might be a gust of wind. It may take you off to the side. So the same thing when you're talking to your patients about pain control with Advil, Tylenol, or stronger medications, you're going to follow up with them. Start with the lowest dose first. Call them in 6 hours, call them in 12 hours, see if you need to modify it. Do you need to give both at the same time? 600 milligrams of Advil, now 1,000 milligrams of Tylenol. Do you need to stagger them? Do you need to do 600 milligrams at time 0 hours? 1,000 milligrams at time of Tylenol at time 2 hours, another 600 milligrams of Advil at time 4 hours. So you need to make it dynamic. It's not a static thing that you can just tell the patient, hey, take this medication and you're off to the races. You need to follow up with them and tell them what to do and how you can make things better. So let's come back to now the pandemic, COVID-19, right? So we are all concerned about giving anti-inflammatories. So let's take Advil, let's take naproxen, let's take aspirin, let's take Toradol or Ketorolac that we have here in the US that you can give PO, not IM, and let's move over to what do we do now in the pandemic era. So you've screened your patient, you know they don't have a fever, they don't have a cough, they haven't been outside of the country for 14 days. You know now with those trick questions that they actually do have an irreversible pulpitis, and you know that you can treat it. Well, I would say start off slow. You know that there's no swelling. A great way to deal with it is just by using Tylenol 3. And the way that I like to prescribe Tylenol 3 is I recommend taking one Tylenol 3 and one extra strength Tylenol at the same time, every 4 to 6 hours for pain. For me, that's an ideal combination of the opioid, codeine, which is 30 milligrams, and then you get pushed up to 800 or 825 milligrams of acetaminophen. And I think that's right in the wheelhouse that I find it really helps patients to control their pain level from their teeth. There's great controversy out there about how much Tylenol in 24 hours you can give. The US has one guideline, Canada has a different guideline, but I think every 4 to 6 hours, if you're at that 825 to 1,000 milligrams of Tylenol, you're going to be okay. If you overdo the codeine, codeine's a horrific drug. It causes nausea, it causes upset stomach, it causes constipation. I don't really like it. So I think at 30, it's quite effective, 30 milligrams, and then having the Tylenol at 825 will work out quite a bit. If you have decided that you need to see this patient in the office and you don't want to use a high speed, because we know making aerosols is an issue for spreading COVID-19 in your dental office, either to yourself or your staff, then another great little trick that's been talked about and we've been discussing as well is to use a steroid along with a long-acting anesthetic. And bupivacaine or Marcaine works really well in the mandible, right? In the maxilla, the maxilla has a lot more perfusion of blood vessels and it doesn't work as well. So I would think in the mandible, articaine still would be a good thing. And what happens when if you brought your patient in, you're not going to drill into that tooth. You're trying to get them out of the pain. You've diagnosed the irreversible pulpitis. There's no swelling. There's no infection that you can see. You've done your intraoral, extraoral exam. You've taken either a CBCT or a PA. Again, taking a CBCT may be safer to generate less aerosols versus doing a PA, but it depends what you have in your office. You see no lesion on your radiograph. You see no lesion in your CBCT. You know it's a pulpitis. Using that anesthetic to break that cycle of pain, and then prescribing for a day or possibly 2 days corticosteroid. After you review the medical history, they don't have diabetes, they don't have any other contraindications, because the contraindication of the corticosteroid is it does increase your blood sugar levels. So if you're a type 1 diabetic and you still have to use the corticosteroid, you may want to you have to tell the patient, not may, that watch your sugar levels. You may have to regulate your insulin a little bit better. You brought your patient in, no swellings, diagnosed IP, you give them the corticosteroid, you give them the anesthetic, 1 or 2 carpioles of the bupivacaine. Let's say we're talking about a lower first molar. You give them the bupivacaine and you give them a prescription for Tylenol 3. You counsel them on how to use the Tylenol 3 with that extra strength Tylenol as well. And you give them right in the office, I would say. I would get for office use, I would get some Decadron or dexamethasone 4 milligrams, have some for office use, and give the patient the steroid at the same time. Hand them a script or a prescription for Decadron, either max, I would say, is 3 days. This protocol was made just on 1 day, 1 at the office, 1 that night, 4 milligram tab. But I occasionally do recommend for a short period of time, dexamethasone, Decadron, 4 milligrams, dispensing 6 tablets, 1 tablet BID for 3 days, along with using that local anesthetic. If you, as a practitioner, don't want to leave your home and you don't want to go in and see the patient, and you've been able to maybe do a FaceTime chat and they showed you their face, you could get your patient to open their mouth, right? And have a look in there, see if there's any swelling. You can get them to palpate in FaceTime and see what's going on. If you can convince yourself they don't have a swelling, you can write them a script for that Decadron as well. And the way that I tell them to take it is 1 tablet first thing when they wake up and 1 at 3 p.m. Because I don't want them to take them much after 3 p.m. because it kind of amps you up. It gives you tons of energy. You're not going to become Superman or anything like that, but it will make you want to stay up and not go to sleep and clean your house. So if you want to go to sleep at a proper time, I say 3 p.m. That's going to sleep at 10 or 12 o'clock at night. So there's 2 ways to use it. Irreversible pulpitis, we're going to be using Tylenol 3 based drugs for the pain, and we're going to be using the steroid to help with the inflammation to bring the pain down. Again, you can bring them into the office, break that pain cycle by giving a long-lasting anesthetic plus the T3 and the steroid, or you just go strictly to not seeing them in the office, no local anesthetic, give them the script for Tylenol 3 plus the steroid. Once you've done that, you check in on day 2 and you see, hey, how are you doing? Is everything fine? If things aren't okay, you have to make a clinical judgment at that point. Are you going to now prescribe a stronger narcotic? For instance, Percocet. Are you going to do a triplicate prescription to get them through? Are you going to risk giving this patient Advil along with the Tylenol 3? I know it's contraindicated for COVID-19, but if no one's allowed out, if we're in New York and we're locked down, no dentists are allowed. We're peaking COVID-19. What are we going to do? Give them a little bit of Advil along with the Tylenol 3 and the steroid. I'm not against it using the ibuprofen, but not as a first-line drug, and only if we haven't been able to get them comfortable. But with that steroid regimen and the Tylenol 3, most people are okay for about a week to 10 days. Lastly, if you can't get them out of pain, they're starting to swell, then there are some centralized clinics that are open that have the proper PPE. There's some endodontic offices that are open. Some of them are even playing with negative air pressure rooms and setting those up. So look at your local authority, your local association, your local college, and find out where you can send them after you've done that initial work for the first 3 or 4 days.
Mm-hmm. All right.
I think that's a few of the things I wanted to touch base with there.
Yeah. Yeah.
I guess that's pain control. The other thing we could talk about is antibiotic management. And we've been talking about a case of irreversible pulpitis. So the most important thing is diagnosis, right? So we have to diagnose. So if you can't diagnose irreversible pulpitis, do not willy-nilly give steroids, okay?
Yeah.
If you've treated a patient, let's say it was just 2 weeks after you've just done a root canal, and you're in week 3 of social isolation, social distancing, self-isolation, and the patient swells up, and you know you did a nice root canal. You were to length, you're happy with the length, and you know the history of your patient. 3 weeks ago, patient was in pain, they were slightly swollen, you did the root canal, swelling went away, everything's going fine, but now they're calling back about the same tooth that it's uncomfortable. Then I think the first step would be to just do some antibiotic management. And the gold standard for antibiotics in endodontics has always been amoxicillin. These are for patients that do not have a penicillin allergy. And a great resource is the American Association of Endodontists. It's called the Colleagues for Diplomats newsletter. It's a 4-page newsletter. I'd encourage everyone to download that. And it can tell you everything about, and Joel might have it here, he can show it to you, here it is. Endodontics and antibiotic update. It was just released in February of this year, I believe, 2020. And is it February 2020, Joel?
Fall 2019, actually.
Oh, fall 2019.
Yeah.
And you know, there's a lot of dogma in endodontics, and like every discipline, every practitioner has their way of doing it. So when we all were trained, it was Pen VK, right? 300 milligrams, 1 QID for 7 to 10 days. Today, a little bit broader spectrum. I think most practitioners who have graduated in the last 5 to 10 years, they've gradually gravitated to amoxicillin. It works in your gram-positive bacteria. It is a cell wall synthesis inhibitor, and that beta-lactam ring that we all learned about. And the way we prescribe it is amoxicillin 500 milligrams, dispensing 21 or 22 tablets if you want to do a loading dose. So let's say we do 22 tablets, 2 stat, then 1 TID until done. If you've already used that drug, then you can add a clavanic acid to it. In Canada, that's called Augmentum, and I believe that's what it's called in the US as well. And that's just it's 125 milligrams of clavanic acid mixed with the amoxicillin. Whenever I give an antibiotic, I always follow up with the patient on day 2. Within 2 days, you should have enough concentration of the antibiotic in the alveolus, in your alveolar bone, so that swelling is going down, the body's able to take care of it. If within 48, I tell people 48 to 60 hours. I know it's 2 days, but I always tell them 60 hours. Under promise, over deliver. If you know it's going to take 72 hours to get that furniture and you get it in 48 hours, you are just as happy as a pig in mud, right? Same thing with anything that I do with patients. Under promise, over deliver. So I tell them 60 hours, but I call them at 48 hours and I say, oh, is that working? How are things going? If they're not working, then I don't switch them because I've already had them on 2 days of amoxicillin. Then I add Flagyl or metronidazole. And metronidazole, I prescribe it today. Flagyl, metronidazole, 500 milligrams, dispensing 21, 1 TID until done. And you're going to use it at the same time as the amoxicillin or the Augmentum. Flagyl or metronidazole works in a totally different mechanism. It disrupts the electron transport chain inside of bacteria. It's really great on anaerobic bacteria. And so the 2 bacteria that we have in a periapical lesion are, well, there's millions of bacteria and viruses and whatnot, but the ones that cause the main troubles are gram-positive bacteria and facultative anaerobes, or they're in an anaerobic environment, they're not using oxygen. So the combination of the 2 usually will get the patient out of pain. Again, follow up, they have their pain medication, and in this case, remember, we're talking about a swelling here, okay? So in this case, no steroid is indicated. You cannot give a steroid in this case. So now this example was, you did a root canal, had some swelling initially, you're happy with your root canal, now they're having some sort of flare-up. So it can't be a pulpitis, right? An irreversible pulpitis assumes that there's tissue in the tooth. You've taken the tissue out, so it can't be a pulpitis. So now we're treating with antibiotics. So now we're assuming over the phone or with our phone diagnosis is that there is a swelling.
Yeah.
That's where we've gone to the antibiotics.
And a lot of dentists, if you've done a root canal on an upper molar and they've got 3 canals and the patient phones them, so they have sensitivity, don't assume that, oh, it's that 4th canal, give them cold sensitivity, because
Right.
I think that's a bit of a red herring. A lot of guys say, oh, they got cold sensitivity from that missed MB2, and it's like, chances are that thing's dead if there was any tissue in there, and chances are the cold sensitivity is not coming from that nerve. Don't beat yourself up for not getting the MB2. And sometimes when people are in pain, they report cold sensitivity, but it is a root canal treated tooth, just because they're so ramped up and they're so motivated to have treatment by us. So you really have to be good with your questions to make sure that, is there cold sensitivity report just because they're anxious and more aware of that area, and or is it because they're motivated to come in to see the super Pommy, right? Like, okay. Right.
Yeah, so
everyone want to see you, right?
100% agree with Dr. Fransen. So yeah, the MB2 is in that particular example, MB2, a month, 2 months after you finish a root canal and you know you weren't able to find MB2 and you thought it was there, is probably not the culprit of the cold sensitivity.
Yeah.
You know, they're having some sort of periapical flare up for whatever reason, right? And so that's when the antibiotics are indicated. And in that case, with the Flagyl, also remember no alcohol. So I've been home all this time, and for the last 3 weeks, I've been eating more, I've been drinking more, just enjoying my life, right? I haven't had this much time off in ages, but now Dr. Fransen has me do this wonderful thing. I'm actually having fun. Who would have imagined I could talk for 30 to 40 minutes nonstop, right? Just like, I'll guide you, I'll do this. I'm like, yeah, I'm gonna need that. But here I am, talking away. So in that college,
totally shocked and stunned.
Shocked, stunned, yeah, shocked everyone, talking away. So I'm trying not to touch my face here, but I did wash my hands with soapy water a few minutes ago. That Colleagues for Excellence, there's a new recommendation for when people have penicillin allergy. We always used to give clindamycin, 300 milligrams, dispensing 28 capsules, 1 QID until done. The new recommendation is, if you're in the US, they will understand what a Z-Pack is, and they'll allow dentists to prescribe that. It is azithromycin, 250 milligrams, dispensing 6 tablets or capsules, 2 stat on day 1, then 1 250 milligram tablet per day for 4 days. So you're dispensing 6 pills. Here in Canada, I've come into trouble with a few people, a few pharmacists, that they won't want a dentist to prescribe a Z-Pack. So they don't want to write down the patient's name and say Z-Pack for the entire script. They want you to write everything out. Azithromycin, 250 milligrams, dispensing 6, 2 on day 1, then 1 pill per day for 4 days. Again, you could follow up with azithromycin as well, in 24 hours or 48 hours, see if it's not working, add the Flagyl, but I think it'll be overkill. If azithromycin doesn't do it, then you really need to bring the patient in and do definitive treatment. Find that area to fix. Find that localized hub of community dentistry where people are organizing to treat these emergencies during the pandemic.
Mm-hmm. Yeah, definitely. No, I think you summarized that really well. And of course, any difficulty swallowing, breathing, all that. Chance of a possible emergency.
And I think we will attach a few of the screening questionnaires before you bring the patients to the office. There's screening questionnaires that you should use that are from Dr. Hargraves and his group. And it's a very wonderful screening. It's only 5. I'm looking at it now. There's only 6 questions there. And if any one of those 6 questions is yes, you shouldn't see them in the office. Like until they've gone through 14 days of isolation. Hey, are you a healthcare worker? Do you work in the ICU? Are you a long-term care facility worker? Are you in one of the care facilities that has an outbreak? If that answer is yes, then it should be obvious to everyone that we're sorry, you have a toothache, you can't come to our office. Mm-hmm. You either have to quit your job for 14 to 21 days, depending on what the recommendation is in your area, and then come and see us.
Yeah.
Okay?
Yeah.
So just all these questions. Have you been outside of the country? Anyone in your household's been in touch with another patient? Do you have a history of fever? Do you have a cough? Et cetera, et cetera. And then that pain scale, It's a wonderful pain scale. We'll send that out to people as well. And I have a little diagram for the medications that we talked about. We can send that as well, just a little quick diagram to go over things with you. And if you ever have any questions, I think, is my email contact going to be as part of this, Joel? Or
Yeah, we can give your email. And the other thing too is we encourage people on the PFX site to post questions.
oh yes,
You'll have access to that. You'll be able to answer the questions. And as people comment on your presentation and you respond, you get more CE for your active
sure, no problem. I'll definitely. I'm going to be. This is my first time on. I think it's a great venue on Pure
FX.
FX. Yeah, it's Pure FX. I think it's really amazing. It's a great venue on Pure FX, and I'm going to be logging in and making an account, and I'll answer everyone's questions there.
Yeah.
What else? What else did you have in your questions, Joel, that you were going to guide me? I can't think off the top of my head. I'd love to spend some more time and chat about things if I missed anything there.
No. Any changes to your pre or post-op instructions because of the pandemic?
Right. So for post-op instructions, again, we are dropping away from the NSAID. So my post-op instruction was 400 milligrams of ibuprofen every 4 to 6 hours for 2 days, no matter what. Everyone had that.
Mm-hmm.
So now I'm switching to 500 to 1,000 milligrams of Tylenol or acetaminophen every 4 to 6 hours for a day or two. Then ice becomes more important. So ice in your face, I really stress that. Use an ice pack from home wrapped in a cloth in the area of work on the outside of your face, 5 minutes on, 5 minutes off. I used to tell people for an hour, but if I can get them to do that for 2 to 3 hours, ice is the old school remedy to be an anti-inflammatory. So I recommend we use that. There's a lot of other wonderful stuff out there that obviously in this early stage of the pandemic hasn't been peer reviewed or tested. But beforehand, we do have a very detailed thing that actually Dr. Fransen has generated on what they can do before they come and visit us at the dental office. And we could share that as well if Dr. Fransen wants to share that. That is very simple. Being clean when you come to the office, clean sheets, rinsing your mouth, salt water mouth rinse, using some vinegar as well for rinsing your mouth out before you come to see us. What we've started at the office is before patients see us, we use 1% hydrogen peroxide to rinse their mouth before we ever see them. When the patients come into the office, we make them wear a mask. We only allow one patient into the office at a time. So there's a lot of things have changed. We've taken all of the chairs away from the front reception except for one. We put up plexiglass barriers that you may be seeing in your grocery stores at our front reception as well. And we're really using all of the PPE that we have available to us and that we've been able to acquire to treat patients when we have to generate an aerosol. But the steps that you have beforehand, be clean before you come in, very detailed steps, using different mouth rinses, using hydrogen peroxide when you actually come to our office, and then afterwards being clean. When you go back to your house, you've been in a non-sterile environment. Let's be real. Dental offices are not sterile, right? So we don't all have negative pressure rooms. We don't want our poor patients to go back, a 7-year-old patient go back to the long-term care facility and spread something that we may have given them. So we are very methodical about telling them to go directly home. Don't touch anything. Take your shoes off. Take your clothes off. Perhaps bag them in the garage. Go straight to the bathroom and take a shower and clean yourself off. And then launder your clothing right away before you go and see your family. And then wipe all the surfaces down that you may have touched using just people are using Lysol wipes or using just very simple bleach. Just like how we clean teeth out, same thing to do for cleaning your surfaces. 50% mixture or a quarter mixture of sodium hypochlorite and 3/4 water. And, daily I'm changing my own routines at home. And those are just best practices that we can tell our patients as well. I'm getting my Amazon boxes and leaving them in the garage for 2 days. Only one person is opening them up. When I come home from the grocery store, only one person goes to the grocery store. When that person goes to the grocery store, they come home and shower. we wipe down the handles that we use to go into the house. And these are the things and the instructions that we're providing to our patients so that, we can keep them safe and society as a whole safe. And we don't want to spread anything from our offices.
No, absolutely. That's absolutely super fantastic. We've covered it well.
All right, awesome.
Well,
thank you so much.
Before, man.
Yeah,
That
was wonderful. Yeah, I really enjoyed that. And again, I thank you, and thank you, PureFX. And if there's any questions, and this is a great thing you started up here, Joel. I'm really proud of you there.
Hey, no, thanks, man. It's I think we got some good information for everybody, and like I said, they'll reach out when they watch this video, and you'll be busy.
Right. And the last thing is that Joel and I, we're wet finger dentists, right? So we're not researchers, and we're just doing these things as best practices that we do in our own offices. Of course, there's multiple different ways to skin a cat, and if I've misspoken, I'll be for any of the regimens I talk about, I'll be the first one to say that yes, I misspoke, and then I'll modify it so I can provide the best care to my patients.
Yeah, this is the best that we can gather at this point in time, and this afternoon, everything is changing. Yeah. So, yeah, do your best to keep up to date, and things are changing faster now than they've changed in the good old days, which is a month and a half ago.
Exactly. Well, thank you very much, everyone. Have a great day, and please stay safe out there.
All right. Thanks, Pommy.